Hello everyone, I Dr. Swaroop welcome you all to my YouTube channel Pathotechy on pathology and technology related videos. If you are new to my channel, click subscribe to encourage us and see the latest on Pathotechy channel. Post your questions in the comment section. This video will be on pathology and the second in the series on the discussion of clinical cases. This video will cover case 7 to 13 on the interpretation of clinical features and laboratory investigations in diagnosing hepatobiliary pathology. The second video is also by Dr. C.S.B.R. Prasad, Professor of Pathology at Sri Devarajaras Medical College, Kolar.
55-year-old male with this liver. So this is again a histopathology, low power view of section from the same liver and high power view of the section from the same liver. And how do you describe these abnormalities and possible causes and also the complications of this. So if you look at the gross liver, the smooth surface is converted into nodular. Probably overall size of the liver is also shrunken, and you can see the nodules of varying sizes, and definitely most of them are more than 3 millimeters in diameter. So it is a macronodular variety of cirrhosis, and the section is showing different nodules, and in between there is some eosinophilic material, probably fibrosis, and this fibrosis is highlighted in the higher magnification. You can see that different size of nodules without any portal triad central vein relationship that is normally seen in a normal liver. So this architecture is lost, and there is nodule formation and fibrosis. So these are the features to say it is a case of cirrhosis. So grossly more than 3 millimeters establishes this as a macronodular variety of cirrhosis. So what is the complication of macronodular cirrhosis? As I was telling in the previous case, they are more prone for hepatocellular carcinoma. So this is case 8, 1-year-old child with deep jaundice, and the LFT showed conjugated hyperbilirubinemia, and the image is taken from a paraoperatively. So you can see that bile duct area, which is represented by a fibrous band. That means absence of bile ducts. Because of this absence of bile ducts, the bile is not entering the small intestine, and this results in deep conjugated variety of hyperbilirubinemia. So this ERCP image, you can see that narrowed bile duct passages, and it is not emptying into the small bowel. And cut surface of the liver again shows a deeply greenish liver with fibrotic areas. Okay, fibrotic areas are they represented by the grey white color structures, and greenish areas are the normal liver with bile stasis. So there are very few causes for deeply greenish liver. The primary thing is biliary atresia. So if you look at the histopathology of biliary atresia, you can appreciate the presence of the fibrosis, and this fibrous bands show proliferation of the bile ducts, and in addition to that there is inflammation. So proliferation of bile ducts is again supportive of biliary cirrhosis, and again high power view of the fibrotic areas where you can see many bile ducts. So the probable diagnosis is biliary atresia. So case 9, 40-year-old male with persistently elevated liver enzymes subjected for liver biopsy. So you are supposed to interpret the liver histology, and portal triad area is shown for interpretation. So here you can see section of the liver wherein there is the portal area is highlighted here. You can appreciate the presence of bile ducts and inflammation, portal inflammation. But if you look at carefully the inflammatory component, they are seeping into the surrounding liver tissue. Such seepage and indistinction between the portal area and the surrounding tissue indicates that there is certain amount of death that is going on in this area, which we will call it as piecemeal type of necrosis. So only few cells will die off, and these inflammatory cells will seep into that area, and fibrosis also starts seeping into that area. So the clear-cut distinction between the liver tissue and the portal area is known as that limiting plate. And when there is disruption of this limiting plate, usually it indicates that there is some chronic activity going on. So this is a case of chronic active hepatitis. So what are the causes for chronic active hepatitis? Usually the viruses, there are very few viruses which can cause chronic active hepatitis. One is, most notable is hepatitis B virus and C virus. In addition to that, there may be B with superadded D infection, or sometimes you may see this drug induced variety of hepatitis also causing chronic active hepatitis. So these patients suffer from waxing and waning LFTs, liver enzymes. So some few months there will be elevated liver enzymes, followed by they back to normal liver enzymes, then again it gets elevated. So it is waxing waning pattern, which is very typically seen in chronic active hepatitis, most notably hepatitis C virus. So next case is liver biopsy from a patient with chronic liver disease. So already biopsy proven, this patient was supposed to be suffering from chronic liver disease, and probably you know the causes for chronic liver disease. Let us interpret the histology. So if you look at the liver tissue, it is showing some vacuolations in the cytoplasm. Probably it is fatty change. In addition to that, in the lower left corner, you can appreciate the presence of eosinophilic material within the cytoplasm of the liver, hepatocytes. So this eosinophilic material is typically seen in the case of alpha-1 antitrypsin deficiency. So one of the causes for chronic liver disease is alpha-1 antitrypsin deficiency. In the course of time, they may land in cirrhosis of liver. And what are the other diseases that may be associated with alpha-1 antitrypsin deficiency? You should not forget pancreatitis, emphysema. And coming to the case number 11, 20-year-old male, fever, icterus, nausea, loss of appetite, all in just 1 week duration, short duration, so that acute onset. And his serum bilirubin is 8 milligrams per dl, and ALT is 2000 international units per liter. So we can appreciate the presence of deep jaundice in this person. And histology of the liver shows the prominent lymphocytic infiltration, forming even follicles, and this lymphocytic infiltration is diffusely present even in hepatic cords. So what is the diagnosis? Acute liver pathology or hepatocellular jaundice. So what are the supportive evidences to say it is hepatocellular jaundice? Look at the history. It is short duration, 1 week duration of symptoms, and elevated bilirubin levels. And this bilirubin must be conjugated variety of bilirubin. And look at the liver enzyme, it is more than 1000. So more than 1000 liver enzymes are usually seen in acute variety of hepatitis, and this is a case of viral hepatitis. So what are the other causes for acute hepatitis? In addition to this, drugs also must be borne in mind, which can cause acute hepatitis. Okay. Moving on to case 12, 40-year-old male with features which are shown in the image. So how do you describe these features, and what do you look for the pathology or manifestation of this feature? So you can see that enlarged breast, and they are sagging, and this is a case of gynecomastia. So in the case of gynecomastia, so what to look for? So you should look for three things primarily. One is you should look at the liver pathology, look at the drug history, and look at the scrotum. That means the scrotum is considered as the 10th compartment of the abdomen. Abdominal examination will not be complete without examining the scrotum. So testicular tumors are known to produce what is known as the gynecomastia. So you should always look at the testes of these persons for possible tumors. If the swelling is not obvious, even then you should send them for ultrasound examination in order to pick up smaller lesions that are lurking in the testicular parenchyma. And in addition to that, you should ask for LFT to exclude the possibility of liver pathology, and you also look into his history. Probably he is hypertensive, taking some antihypertensive drugs which are known to be associated with development of gynecomastia. In addition to these three, that is drugs, liver and testis, the patient sometimes may have adrenal pathology in the form of adrenal hyperplasia or some tumors which may be causing this type of clinical manifestation. So gynecomastia is not a diagnosis, it is only a symptom or the sign which is leading on to a more severe pathology within. So case 13, a 47-year-old male with increasing abdominal distension found to have ascites and abnormal liver function tests. So here it is just probably time is not mentioned, probably it is an acute onset and middle-aged man with increasing abdominal distension. That means there is some accumulation within the abdomen which is causing rapid increase in size of the abdominal girth. And of course here also mentioned that ascites is present because of which was picked up by ultrasound examination, and abnormal liver function test probably again suggests the pathology within the liver. So if you look at the liver scan, which is representing the portal, this hepatic veins, and there is some discontinuity in the shadow. You can see that two hepatic vein radicals, and the darker area represented by V like darker area, and they are not progressing further. That means there is something within the lumen. So it is a hepatic vein thrombosis. So you can see that hepatic vein thrombosis getting operated, and they are putting a stent to rejoin hepatic veins with the inferior vena cava. And what is that syndrome? What is the name of the syndrome where there is hepatic vein thrombosis associated with increased abdominal distension, ascites, and altered liver functions? It is Biliary syndrome.
Thanks for watching. Do subscribe to this channel.